intubations. Let's talk about a little bit about this. We have to prepare for an ALS airway. And so basically what we're doing is we're going to make sure that our patient is unresponsive and that the airway is open with the head tilt, chin lift, but there isn't any air movement. Hopefully there is a pulse. So we have an apneic patient but has a pulse. Measure the appropriate OPA, place that in, and then start to ventilate our patient with the bag valve mask, making the CE technique. Now this is going to go quickly. We get our 2 breaths in. We're going to pass this apparatus off to our secondary rescue to continue to ventilate 1 breath every 5 to 6 seconds. In the meantime, we need to prepare. Now if the patient couldn't take care of this, we would put an MPA in. And if they have a problematic airway, we have our suction device ready to go. Now as our secondary rescuer, our partner, is ventilating the patient, here 1 breath every 5 to 6 seconds, we are setting up for our advanced airway, and our advanced airway here would be an intubation. We're going to make sure we have the different tube sizes. These are cuffed. We have to have a type of stylet to make the tube a little rigid, a 10 or 12 cc syringe so we can inflate the distal cuff there. We need to also have a securing device. This is the Thomas tube holder. We'd also have a tube extension and a colorimetric device, and later on we'd also include capnography. Make sure we also have different tube blade sizes and the Mergeau's forceps. So here we have 2 different blade sizes, a straight blade and a curved blade. Here we're looking at, this is the Wisconsin 4. You can tell on the back side of the blade, it'll have the number here. As well as this is a Mac. And sometimes on the side, it'll also show you Mac 4 or Mac 3. I just have a standard blade here, handle here. We'll also make sure that we have some bailout or backup devices with supraglottic airways. This is a king tube with our tube syringes. And then if we need, again, you heard our suction was ready to go. So as we prepare, it's quickly. Practice with 1 blade. I would prefer that you guys learn to use the 1 blade only for a while until you get better at it. I'd suggest using the straight blade. You can go ahead and use the curved blade. It's just a matter of opinion. I'm checking the blade that the bulb is on tight, the light is bright, and it's a white clear light. I'm gonna make sure that's ready to go. I'm gonna make sure that my tube and my stylet's kept in the sterile packaging. I don't want my stylet to go beyond the distal tip or the opening of the ET tube. I'm gonna take my syringe. I'm gonna connect up to the pilot balloon. Gonna fill that up with about 10 to 6 cc's of air to just see if the distal balloon inflates. Now I'm gonna keep back pressure on the plunger so I can squeeze the distal balloon and the pilot balloon so that we don't have any leaks in there. And I wanna make sure I draw that air out so that it deflates the cuff there, so when I intubate, we're not gonna be obstructed in any means or fashion. So we have pretty much all of our things kind of set up. You need to set it up in the manner that you are comfortable with. Again, this is just for the practice setting, but if you practice like if it's for the real world, you'll be able to complete this assignment and this task and then move on to managing your call. So your partner has been ventilating, probably assume the position that you want to be in. So you want to take over the position and then move the partner around. You're going to continue to ventilate 1 breath every 5 to 6 seconds, and then evaluate how your patient is doing with the blood pressure, pulse oximeter, EKG. Look at those vital signs and determine now, is this something that you have to do right now, or are they satting well? Are you ventilating well? Are you getting good air exchange? We'll pass this bag off. You want to tell your partner to do some things while you're doing your own thing, but it's basically take the blade out, the OPA out, put the head in a neutral position. I use a tongue jaw lift here so that you can introduce the blade. You rotate the handle and the blade so that it holds the curvature, and then you lift up. You'll have a partner help you with the placement of the tube and taking it out of the bag. I see it past the vocal cords. I hold onto the tube the whole time. I go ahead and pass those vocal cords just a little bit so that I can see the black tips going down, and then we can start to ventilate. Now I get 1 breath, I get my 2 breaths, and I want to now assess my lung sound. So I'm going to pass this breathing apparatus off to my second rescuer while I listen to my lung sounds. I should clear lung sounds negative epigastric sound. Long sounds, long sounds, long sounds, long sounds, negative epigastric sounds. Again, once we have tube placed conferment, we can also use what's called the end tidal CO2 or capnography. You'd have this device, the tube extension. You put your end colorimetric device, probably used only one time, placed here furthest down above the tubes here so that you can see that yellow and purple changing during the ventilations, during your ventilations. As we change over and we move over to our colorimetric, from our colorimetric to our capnography, again, we want to get down as close as possible so that we can get the best reading from this device as it goes back and gives us a waveform. So not only do we listen to lung sounds and confirm that, not only do we hear negative epigastric sounds, we also visualize the tube passing the cords. And we have confirmation based on our colorimetric device and our now capnography and capnometry. Now we can go ahead and secure this. Continue to hold on to the tube so that you don't displace this. Look at the lip to tip measurement, and you know we're about 20, 21. It depends on what size tube you used. And so we're about down there. We got good lung sounds. Everything is inflated. We'll go ahead and secure the device. In the meantime, your second rescue would continue to ventilate the patient using the bag valve mask and connecting this back up. And we're doing one breath every 5 to 6 seconds, 10 to 12 breaths per minute. Now that's just the starting rate. And remember that if your patient is breathing faster, you may have to match their breathing rate because we don't want to slow it down by any means. It may be a physiological reason why they're breathing faster. Okay, just some quick things then. Volume sizes, if we're going to give them 6 to 8 cc's tidal volume per kilogram of natural body weight. Again, we had all the tube sizes. We had our laryngoscope blades. We had our basic airway. We even had our suction. We had our bailouts or our secondary airway devices, our supraglottics. Then again, we could have always gone back to our basic BLS airway. I know this is pretty quick. I'm just gonna need you guys to sort of practice this quite frequently. Again, it's just an eye and hand and muscle memory that you develop. Again, so let's go over a little bit. You have this tube extension here that was initially connected to your colorimetric device. This colorimetric device confirmed tube placement after we listened to lung sounds and negative epigastric sounds. And we connected up to our end tidal waveform and capnometry. We didn't secure the tube until we had good confirmation because we don't want to have malplacement of our intubation and we'd be ventilating in the epigastrum or the gastric area, causing gastric inflation. Now after we intubated, we put the blade in, we went and visualized the cord, and we went and placed the tube just a few centimeters beyond that so that we can see the tube passing the cuff, and we're probably placing it just in between these two folds here so that it doesn't go too far down the right main stem bronchus, and we have a right main stem bronchus intubation, and we get negative lung sounds on the left. So here you have some color markings that allow us to see when we're passing the tube through the vocal cords where we want it to sit. Again, this is then inside a sterile bag, and in that sterile bag we tested these cuffs, both the distal and proximal balloons. One was the pilot balloon, and then we have the distal cuff. In there we also had our stylet that was in there that we took out. Our stylet was not to go further than the distal tip of the eye here, and we have sometimes what's called a Murphy's eye. So right here on the side of this tube, if you can see right on the side here, there's another eye. So we don't want this end of the distal stylet to go way past this. And we're not trying to make drastic turns here. It's not supposed to be hooked. We just basically want a slight, if any, little tip so that we can kind of align it going up. It also allows us, if we have to, we'll draw back on the stylet, and what happens now, the stylet as it's being drawn up allows this lift to become more anterior so we can place it into the between the glottic opening. Again, this is left inside the tube packaging, and we tested our cuffs, both our proximal and distal pilot balloon and our distal cuffs. making sure that we had about 6 to 8 cc's of air. We don't want too much to cause any necrosis. Before that, then we had our basic airway that was placed in. We had opened the airway and we had placed the OPA in. And we would started to ventilate the patient using our bag valve mask. Remembering 1 breath every 5 to 6 for an adult, 10 to 12 breaths per minute, about 500 cc tidal volume. And this began when we checked the airway. We checked for responsiveness using some supraorbital pressure here or even a trapezius pinch. We noticed that the person did have a pulse but was not breathing, and we went on with our basic maneuvers. So please practice your intubations, practice the BLS airways. They both go hand in hand. You also need to identify a partner so that you guys can both work together on this skill.